Good afternoon. I would like to thank the organizers for inviting me to give this talk on the use of monoclonal antibodies in rheumatic diseases. I thought I would start with a very brief overview of the most common rheumatic conditions that we use for monoclonal antibodies for. Rheumatoid arthritis is one of the most common inflammatory arthritic conditions. It is characterized by articular inflammation and synovial joint damage. Tumor necrosis factor and interleukin-6 are pivotal cytokines, and monoclonal antibodies that target these are very helpful in the management of rheumatoid arthritis. The seronegative spondyloarthritis are inflammatory arthritic conditions that are unified by lack of rheumatoid factor, hence the seronegative label. This umbrella term encompasses psoriatic arthritis, enteropathic arthritis, reactive arthritis, and ankylosing spondylitis. These conditions are unified not only by their lack of seropositivity, but also by a similar spectrum of extraarticular manifestations that involve the eyes, the skin, and the gut. As the illustration suggests, each organ has a peculiar cytokine profile associated with disease, though TNF is a common cytokine throughout. The vasculitides are conditions that, by definition, involve inflammation of blood vessels. These are traditionally grouped according to the size of the blood vessel involved. Disease manifestations are related to the organs supplied by their respective blood vessels. In the large vessel vasculitides, which typically present with symptoms of temporal arteritis, extremity claudication, or significant systemic symptoms such as fever, treatment with anti-IL-6 or anti-TNF is recommended. In the case of the ANCA-associated vasculitides, the manifestations are typically related to small vessel disease, so lungs, kidneys, and skin are often involved. Guidelines suggest treatment with rituximab. The multi-system autoimmune conditions involve multiple organs, as demonstrated by this illustration of SLE. They are defined by the presence of autoantibodies. As such, depleting B cells has been widely used off-label, though the mechanism by which this works is not explained solely by antibody reduction. Similarly, the inflammatory myopathies are often typified by the presence of autoantibodies, so treatment with rituximab is also widely used off-label. Broadly speaking, the role of monoclonal antibodies in rheumatic disease is to either interfere with cytokine function, such as with the cytokines listed here, or to deplete B cells. Moving on, we will now discuss the blockade of cytokines, starting with TNF. TNF is a pro-inflammatory cytokine that is produced by activated macrophages, T cells, and NK cells. Among other functions, when it binds to its receptor, it stimulates the release of other inflammatory cytokines such as IL-1, IL-6, and GM-CSF. TNF blockade is very effective for the management of many of our diseases, and so is universally recommended in our treatment guidelines, both from the American College of Rheumatology and from the European League Against Rheumatism. These are the currently available anti-TNF monoclonal antibodies. Infliximab was the first monoclonal approved for the treatment of rheumatoid arthritis back in 1998, and the other monoclonals were subsequently approved in fairly rapid succession. You can see on the rightmost column that these agents have broad approval in a variety of autoimmune diseases. This forest plot is taken from a meta-analysis looking at the efficacy of anti-TNF agents in rheumatoid arthritis. The outcome measure here is an ACR 50. The ACR 20, 50, or 70 is a global index of whether a patient achieved a 20, 50, or 70% improvement in their disease, taking into consideration the number of joints involved and the patient's pain and function. In this graph, we are looking at ACR 50 responses versus control or placebo at 6 months of therapy. In case anyone is not familiar with this plot, what we have here is a list of the different agents with different trials that looked at those agents. The diamond is a statistical summary of the effect of the drug across the studies. Having the diamond be completely to the right of the vertical line means the risk ratio is statistically significant and favors the intervention. So this paper demonstrates the superiority of anti-TNF agents in the management of rheumatoid arthritis. Similarly, here's another forest plot, this time looking at the efficacy of anti-TNF agents in psoriatic arthritis. The outcome measure here is the ACR70 at 12 to 16 weeks of treatment, and the TNF agents are clearly effective. These agents are generally well tolerated. The biggest adverse effect that we worry about is infection. TNF is important for the maintenance of granulomas because it plays a role in the recruitment of monocytes, the differentiation of monocytes into macrophages, and subsequent activation of the macrophages. Because granuloma formation is important in the containment of mycobacterial and fungal infections, we screen patients for latent TB, and we monitor for the development of certain fungal diseases, especially where these infections are endemic. We also screen for the presence of chronic or prior Hep B infections because there have been reports of Hep B reactivation. Another potential adverse effect is the induction of autoimmunity. This is not unique to the anti-TNF monoclonals, but relevant to rheumatologists, anti-TNF agents can cause drug-induced lupus. Now, because of this induction of autoimmunity, it is common practice for gastroenterologists to monitor drug levels as a surrogate for the presence of neutralizing anti-drug antibodies. This practice has not really taken hold among rheumatologists. This trial out of Norway, published in 2021, looked at the role of therapeutic drug monitoring versus standard therapy in 411 patients with various autoimmune diseases initiating infliximab. The choice to study infliximab is a good one, since infliximab is a chimeric monoclonal, and the development of human anti-chimeric antibodies has been reported to be as high as about 60% among rheumatoid arthritis patients, for example. This graph represents disease activity in the various conditions at various time points. Orange boxes represent patients who were managed using a strategy of therapeutic drug monitoring, and blue boxes represent those managed with standard therapy. As you can see, therapeutic drug monitoring did not affect remission rates across all these diseases. The next big cytokine target is interleukin-6, which is a major pro-inflammatory cytokine involved in innate immunity, but also has an essential immunoregulatory role in adaptive immunity. This is an illustration of some of the biological effects of IL-6. IL-6 promotes joint inflammation through its effect on macrophages and fibroblasts. It contributes to bone and joint destruction via its effect on osteoclast differentiation and activation. In addition, it directly drives the acute phase response, and it plays a role in proliferation and terminal differentiation of B cells, and in regulating the differentiation of T cells into either a pro-inflammatory Th17 or a regulatory T cell. There are two currently available IL-6 receptor blocking monoclonals. You may be aware that tocilizumab was given emergency use authorization by the US FDA for management of patients hospitalized with COVID pneumonia. Now, because the anti-TNF agents have been so effective for our diseases, head-to-head trials are now, in a way, the standard by which we evaluate new drugs. This graph is taken from one such head-to-head trial comparing monotherapy with the IL-6 receptor blocking antibody tocilizumab versus the TNF blocker adalimumab in over 300 biologic-naive RA patients. On the x-axis, we have the various disease measures, and on the y-axis, we have the percent of patients achieving those measures. The pink bars represent patients treated with adalimumab, and the blue bars are patients treated with tocilizumab. This study was pivotal and led to the European League Against Rheumatism recommendation that anti-IL-6 is preferred for patients with rheumatoid arthritis who cannot be treated with conventional disease modifiers. This slide is taken from a trial of tocilizumab in giant cell arteritis. This is one of our more challenging diseases. Before this trial, steroids were the only drug reliably effective in giant cell arteritis. This led to a lot of long-term steroid use with quite a bit of complications. This trial looked at 251 patients who were given either tocilizumab in 2 different doses or steroids alone. This curve demonstrates that the 2 tocilizumab groups in green and purple were significantly less likely to flare compared to patients who were treated with steroids alone. This led to the approval of tocilizumab for use in giant cell arteritis. Next, we move on to the IL-23, IL-17 pathway. IL-17 is the pro-inflammatory T cell cytokine. It is produced primarily by Th17 cells, but also by other cells of the immune system. It promotes the release of additional pro-inflammatory cytokines such as TNF, IL-6, IL-1, and GM-CSF, and also of chemokines and matrix metalloproteinases. IL-23 is a product of antigen-presenting cells, and it regulates the production of IL-17 by Th17. The cartoon on the right is a depiction of different organs involved in the seronegative spondyloarthropathies and cytokine blockade that has been shown to be effective in these organs. Blocking TNF is universally effective, it seems. Blocking IL-17 is effective except in the gut, and blocking IL-23 is effective except in the axial skeleton. Notably, in mouse models of arthritis, IL-17 overexpression induced RA-like pathology, but IL-17 blockade in humans has not actually been effective in RA. On the other hand, both IL-17 and IL-23 blockade has proven very effective in skin psoriasis. This forest plot is taken from a meta-analysis of biologics in psoriasis and psoriatic arthritis. This particular graph shows the effect of different drugs on the PASI 75. PASI is the Psoriasis Area and Severity Index, which scores the lesions according to the extent of erythema, scaling, and induration, as well as the extent of body surface area involvement. A PASI 75 means 75% improvement in the PASI score. At the top, we have the anti-TNF agents. Next to that are the P-Summit trials, which use the anti-IL-23 agent ustekinumab. And in the third section are the trials that used anti-IL-17. The future trials used secukinumab, and the SPIRIT trials were trials of ixekizumab. It's easy to appreciate from this graph that all of these agents are beneficial. This paper also included analyses demonstrating the same efficacy for dactylitis and enthesitis, though I did not include those plots here. This is another head-to-head trial using adalimumab as the active comparator. The condition here is ankylosing spondylitis, and the trial drug is ixekizumab, an anti-IL-17 agent. 341 biologic-naive patients were randomized to either drug or placebo, and the outcome measure at week 16 is the ASAS-40, which, as you may have figured out by now, is a 40% improvement in relevant disease parameters in ankylosing spondylitis. This graph shows that the anti-IL-17 treated patients, shown in blue and red, did just as well, if not better, than the patients treated with the anti-TNF agent in purple. This study led to the approval of ixekizumab for the treatment of AS. Here's another head-to-head study comparing the IL-23 blocker risankizumab with adalimumab, this time in moderate to severe plaque psoriasis. IL-23 blockade, shown in orange, is superior to TNF blockade. And here is yet another head-to-head trial looking at IL-23 blockade with risankizumab in plaque psoriasis. This time, the comparator is not an anti-TNF agent, but rather the IL-17 blocker secukinumab. One important caveat here is that this trial was randomized but open label, so the patients knew what they were getting, but the efficacy assessor was blinded. The endpoint here is a 90% improvement in PASI, and while the drugs were equal at week 16, IL-23 blockade was superior at week 52. So we've shown that IL-17 blockade is very effective for the treatment of psoriasis, psoriatic arthritis, and ankylosing spondylitis, and that IL-23 blockade is effective for psoriasis and psoriatic arthritis. It seems logical that IL-23 blockade would work for AS. In mouse models, IL-23 overexpression leads to enthesitis and sacroiliitis. This effect is mediated by gamma delta T cells producing IL-17, which promotes bone growth. Follow-on human studies showed that these IL-17 producing gamma delta T cells, which express IL-23 receptors, are indeed present in patients with ankylosing spondylitis. However, IL-23 blockade has not been shown to be effective. The graph on the top right in grayscale shows the summary of 3 randomized controlled trials demonstrating that ustekinumab, which blocks the P40 subunit of IL-23, is no better than placebo. Similarly, the bottom graph shows that risankizumab, which blocks the P19 subunit, is also no better than placebo. So perhaps there's an IL-23 independent mechanism of IL-17 production in AS. Switching gears slightly, the next two cytokine targets are relevant to the management of SLE. These are B-cell activating factor, or BAFF, also called BLyS, and interferon alpha. Beginning in the early 2000s, it became apparent that patients with SLE had a pronounced interferon signature, and that type 1 interferon signaling is associated with increased disease activity. It is thought that plasmacytoid dendritic cells release type 1 interferon in response to increased cellular debris from apoptosis and mitosis. Interferon then promotes B-cell differentiation and loss of tolerance, which results in autoantibody production. This leads to immune complex formation and further cell destruction, thus propagating the vicious circle. The schematic on the right shows potential ways to target B cells to interrupt the cycle. BAFF is essential for B cell survival and maturation into antibody-producing cells. BAFF acts on the BAFF-R, TACI, and BCMA receptors, and this cartoon of B cell maturation illustrates that some or all forms of BAFF receptors are located on immature and mature B cells, plasma cells, and memory B cells. So targeting BAFF targets all of these B cell populations. Belimumab is a monoclonal antibody that targets soluble BAFF. This graph comes from the BLyS 52 trial, which was a trial of belimumab in over 800 patients. On the basis of this trial in 2011, belimumab was the first biologic to be approved for use in SLE. Incidentally, it also was the first drug approval for SLE since hydroxychloroquine was approved in 1955. In all of these graphs, the gray line represents placebo and the purple line represents the active drug at the dose currently used. The point to make here is that with regard to disease activity and reduction of steroid dose, as well as biologic parameters such as normalization of complement levels, belimumab was shown to be superior to placebo. Anifrolumab is a fully human monoclonal antibody directed against the type 1 interferon receptor. TULIP-2 is a phase 3 trial in which 362 patients were randomized to receive monthly anifrolumab versus placebo. More patients in the treatment group achieved a response in the composite endpoint. This study, published in early 2020, was one of 3 trials that led to the ultimate FDA approval of this drug in August of 2021. And finally, we come to B-cell depletion. I really have not dedicated much time to this because you all are the pioneers in using B-cell depletion therapy. But briefly, as it relates to rheumatic conditions, it seems that the benefit of using rituximab goes beyond reducing antibodies. Because in addition to producing antibodies, B cells also act as antigen-presenting cells, and certain B cell subsets also produce pro-inflammatory cytokines such as TNF, IL-6, and VEGF. Synovial B cells also secrete rank ligand, which plays a role in the development of bone erosion seen in inflammatory arthritis. In rheumatology, rituximab is only FDA approved for use in rheumatoid arthritis and in the ANCA-associated vasculitides, but it is commonly used off-label in many other conditions. One healthcare utilization study out of Kaiser Permanente in Colorado showed that off-label use of rituximab went from 1.2% in 2009 to 55.6% in 2017. These are just some examples of randomized controlled trials using rituximab in various rheumatic conditions. This is just a fraction of the voluminous literature on using rituximab off-label. One reason that it is not more widely approved for our diseases is that our diseases are rare, and even within diseases, there's such a clinical heterogeneity. So within the rigid design of a clinical trial, success can be difficult to demonstrate, even though in the clinical setting, patients and physicians might consider the treatment successful. And in the spirit of that optimism, here are the various B-cell depleting therapies that are currently being studied for autoimmune conditions. Thank you very much for your attention.